So good morning, everybody. So today I'm going to be talking about dementia-related behavior and the role of medications in addressing these behaviors. So this is the sponsor slides over here. Um, okay. All right. So before I start talking about dementia-related behaviors, I want to go over different types of dementia types. So the most common type of dementia is Alzheimer's dementia, which is characterized by tangles and plaques that you may have read about in the brain. And the most second common type of dementia is known as dementia of Lewy bodies. And this is a little bit different from Alzheimer's in the sense that it has more visual hallucinations, REM sleep behavior, which is, somebody acting out, kicking, in their sleep, and more Parkinson-like features. And a very close third type of dementia, a little bit behind Lewy body, is vascular dementia. And this is usually from a person with, a series of small strokes, or large strokes. And what we have realized for the last 10 years or so is that a lot of people have sort of have what's known as a mixed dementia, a combination of different types of dementia, usually Alzheimer's plus Lewy body dementia or vascular dementia. And then there are lesser common dementia types, such as frontotemporal dementia. But for the purpose of the talk today, I'm just going to focus more on Alzheimer's dementia because it is the most common type. So behavioral and psychological symptoms of dementia is present in majority of the people with this illness. It's usually a main cause for a premature institutionalization, also predicts higher mortality. And not only does it cause a lot of suffering for the patients, it also has it causes a lot of a high degree of caregiver burnout, especially in terms of depression. So this graph shows that in the general population, at any time, we estimate that there is about 5% of people with clinical depression. However, among caregivers, full-time caregivers of people with dementia, the prevalence of depression is over 30%. So 6 times the risk of depression compared to a general population. So this kind of issue is going to be worsening. The problem is going to be worsening. We need more resources because Alzheimer's dementia is present. If we look at people that are 85 years or older, it's seen in 30% or higher in this age group. And the number of people with dementia, Alzheimer's dementia in the United States is going to double from 7 million people right now to 13 million by 2050. Okay, so BPSD or behavioral psychological symptoms of dementia can be broken down into this list of different clusters of symptoms, which will help the doctors to define, what they are and to seek specific treatment for the individual symptoms. So these include psychosis, agitation, anxiety, apathy, sleep disruption, and depression. And the reason I have psychosis and depression in red is because these are the two symptoms that are most associated with physical aggression, and they're fairly reversible with consistent treatment. And we're going to go over through this list one at a time right now. Okay, so psychosis in dementia, psychosis in itself means loss of reality testing. So they're sort of, living a different reality from what we consider, reality ourselves. And this usually involves paranoid delusions, visual hallucinations, leading to a lot of accusatory behavior, if not physical aggression. And it can worsen, and psychosis can worsen as the dementia progresses. And as I had talked about just now, psychosis and dementia can predict physical aggression, earlier placement, from a patient's home setting, as well as a higher risk of death. Depression in dementia is also something that we should be screening for as early as possible in the course of the illness. A lot of people with dementia, because of cognitive decline, they're not able to tell you that, hey, I'm depressed. However, some of the telltale signs of depression in dementia includes irritability, So someone who is very, very irritable, more than usual for weeks or for months, then, we probably have a pretty good idea that, there could be some kind of underlying depression. And some of the associated features of depression, besides irritability, is they get angry easily, they're rejecting help, they're making effort not to engage, making effort to isolate. And this is present in about 20% of Alzheimer's dementia. So like psychosis in dementia, depression itself, if untreated, can predict physical aggression, a higher risk of death, as well as faster memory decline. Okay. And apathy in dementia. So apathy in itself means that, the, the patient with apathy in dementia, they're just kind of indifferent. They don't really care what's going on. They're not that angry. They're just sort of kind of couch potatoes sitting there, not doing much, not motivated to do, go through their routines a lot less than they used to. But unlike depression and dementia, a person with apathy, they're not irritable. They're not angry. They don't have that poor mood. And this could be pretty common, and usually the caregivers are more worried about this, than the patient themselves. Usually they're, caregivers are not worried about, they're not eating as much, they're not engaged in activities, and also they're just not engaged in personal hygiene, like just making sure, they're clean. So usually, and as instead of using medication to treat apathy, we usually work with the caregivers on just making sure people with apathy have access, to, sufficient food, and that their personal hygiene is well maintained. Okay, and the next cluster is, anxiety and agitation in dementia. And this is usually described by caregivers as, somebody who is fairly very restless, and which could be a combination of, different impulsive, intrusive behaviors. Could be verbal, could be physical, and could be sexual. However, unlike depression or psychosis, which is sort of this constant psychotic state or constantly depressed state, a person with this kind of symptom in dementia, it's usually specific to a trigger or a context. So, for example, a person will be doing okay, except during care, when they're trying to get changed, when they would resort to agitation. Or a person will be doing well, except for when talking or dealing with certain individuals. This is where some of the sexual inappropriate aggression may come out. And because of the triggers that could be easily discerned by caregiver, this is where non-pharmacological approaches can go a long way in decreasing this kind of behavior, as opposed to relying on medications alone. Okay. Um, and then the last category for dementia-related behavior is, sleep disruption. So as we all get older, especially those with dementia, the following changes accelerate. And these include, it just takes longer for people to fall asleep. Also harder for people to stay asleep, and also as we all get older, our sleep is just not as refreshing. We don't spend as much time in what's known as, deep restorative sleep. And what is the consequence of, worsening sleep patterns or not getting enough sufficient sleep is that poor sleep is also associated with a risk of having dementia, as well as accelerated progression of dementia. And also it's a huge factor for caregiver burnout, because the caregivers are having to stay up all night, just make sure they don't elope or they don't fall, because things are, turning on and off the lights, tripping over things. So something that's also we're going to be talking about in terms of what could be done pharmacologically and non-pharmacologically later on this talk. Okay. And before we start talking about medications for dementia-related behavior, we also want to look for other signs or causes for agitation in dementia. And this usually could be usually from either a person is medically ill or they're just not comfortable. So acute medical illnesses, usually, we see this, as respiratory infection, or, even more commonly, a urinary tract infection, or UTI, can be the, acute cause for someone with acute onset, usually within a few days of escalating behavior, sort of out of the blue, with very poor attention. And this is, known as delirium. So whenever, whenever caregivers report signs and symptoms are consistent with delirium, we would ask them to work with a primary care physician to make sure that they're not acutely medically ill. And often a new medication, especially medication that are anticholinergic, can cause a lot of behaviors such as confusion, constipation, and agitation. So it would behoove the caregivers to tell the doctors, hey, if there's any new medication that's just been started recently, that seems to be associated with a new type of acute behavior. And also one thing that I screen for all the time, pretty much every day, every time when I evaluate a person with dementia is constipation. There's enough studies showing that constipation is a well-identified risk for aggression in dementia. So ideally, we would like to see somebody having a BM, every day, and if not possible, with dietary modifications, sometimes I would suggest that maybe a daily use of Miralax will be, it's over-the-counter supplement. Daily use of Miralax will be one of the safer ways of treating constipation in people that are older. Um, and Okay. And then the last cause of agitation in dementia is pain. And this is very important because a lot of people with dementia cannot tell you that they're hurting. And so it'd be appropriate to look at other causes or screen for pain, especially skin ulcers, especially for somebody who doesn't move a lot. And if needed, usually one of the safer treatment for pain is just acetaminophen or Tylenol, which has been shown to decrease agitation before considering stronger medications such as, that may have more side effects. Okay. Um, so so when are medications appropriate and necessary in dementia-related behavior? Yeah, this is something you want to consider, especially when the behaviors are just kind of unmanaged or out of control, because behaviors are escalating without any treatment. Actually can cause more physical symptoms or medical problems such as increased falls, infection, and it's kind of like a snowball effect. One behavior that is untreated can beget even more behaviors. And the whole goal of treatment with medication is to try and maintain that quality of life, for the safety of the patients and safety of the caregivers. So this slide shows that as the dementia, symptom severity increases with time, there's a decreased quality of life. And with non-medication approaches, which is what Dr. Wayne and Dorothy is going to talk about, the non-medication approaches can try to help to maintain that quality of life. But as the symptoms become more severe, there's only so much we can achieve with non-pharmacological interventions. And this is where medication use will be appropriate to try to maintain that quality of life. However, it can be a double-edged sword because inappropriate use of medications can lead to side effects and thereby decreasing the quality of life. Okay, so what are some of the medications that could be, that have been used for dementia-related behavior? For decades, most of the medications we use are based on studies and evidence. There's really not a quote unquote FDA-approved medication because it's just very costly to design a study that would meet FDA standards. Um, However, last year there's a medication known as brexpiprazole or Rexulti that's the first FDA-approved medication for dementia-related agitation. However, jury is still out whether this medication is going to be any more effective than the medicine that we're already using. But we know for sure it's going to be a lot more costly than the $4, $6 formulary that you can get from, Walmart or Walgreens. So in choosing medications, we want to choose medication with high benefit versus risk ratio. So if we array all the different types of medication that's been used for dementia-related behavior, um, you can see that the antidepressants, or in this case, serotonin reuptake inhibitors, selective serotonin reuptake inhibitors such as citalopram, and antipsychotics, which include brexpiprazole, sort of are placed in this sort of higher benefit because they're more effective area. But the big difference is that antidepressants like SSRIs are lower risk, that there's less motor symptoms, less side effects overall compared to antipsychotics. And because of this, we try to use antidepressants as first line in treating different types of dementia-related behavior. Okay, so speaking of antidepressants, if we go back to the list of different clusters of symptoms of BPSD, you can see that antidepressants still sort of regarded as first line treatment for depression, for psychosis, and for restlessness or agitation if needed. And what is interesting is antidepressants is as effective as antipsychotics for psychosis in dementia. Whereas if there's psychosis from schizophrenia, you do not want to use antidepressant. You would want to make sure that you use antipsychotic to treat that. But in psychosis in dementia, antidepressant has been shown to be as effective and safer and as a first line choice. Um, However, for apathy, this is when a person just kind of sits there not doing much. There are times that apathy could be so severe that the patient has significant weight loss, poor personal hygiene, and caregiver just had a hard time sort of keeping up with that decline. And this is when use of dementia medications like cholinesterase inhibitors, like the which is Aricept, or stimulants like Ritalin, can be effective. You do want to avoid use of antidepressant in apathy because you can make the apathy worse. Okay. And for sleep, I'm usually very reluctant to consider medication for sleep because medication for sleep often can, increase sedation, increase the risk for falls. So I usually like to focus on sleep hygiene, make sure that it's optimized first. So sleep hygiene usually for people with dementia involves just make sure that they're stimulated, that they're exposed to sufficient activities, and also minimal naps. I always tell the caregivers to make sure that they don't take naps longer than 30 minutes because the whole point is if the body is too well rested during the day, they're not going to sleep well that night. Um, and however, there are circumstances where you just need medication for sleep because there's no one to watch the patient at night. And this is when a lot of them would elope, from the facilities or from the home. And this is when, you can consider treatment. Melatonin is a supplement at low doses, has been shown to be helpful to establish that sleep-wake cycle in people that are older. Because as we get older, we just don't make enough melatonin at night. And so this would help to replenish that. There are a long list of sleep medications that could be used. I don't want to go into the details, but definitely I tell people to avoid over-the-counter Benadryl, which is very anticholinergic and can cause constipation, which is a risk for aggression, as well as confusion. And speaking of FDA approved medications, actually it's it's there are actually some newer medication that seems to be that are FDA approved that seem to be very effective and better tolerated for people that are older. And these include low dose doxepin, and then the orexin antagonists such as suvorexin and lemborexin. These are fairly new medications, but the studies have shown that this is probably offering promising alternatives in the future in terms of sleep medication that are well tolerated. All right, so we're toward the end of the talk today. What can the caregivers do in a doctor's visit to help the doctors decide whether medications are necessary, and if medications necessary, what type of medications to prescribe? So always bring a complete list of supplements and medication that the person is taking. Be ready to describe one or two examples of what the difficult behaviors are and what non-pharmacological intervention have been tried, and whether these behaviors have led to serious safety concerns or caregiver burnout. And for sleep, um, it's also good to notice sort of odd symptoms of sleep patterns, such as going to the restroom all night or acting out in their sleep, holding their breath or kicking their legs at night, because a lot of these can be signs and symptoms of treatable medical illnesses. And if once treated, the sleep would, the sleep quality would improve a lot. So once the treatment is underway, most doctors, we try to start with a low dose medication just to make sure that they're able to tolerate it. And even the medications at a good dose, it may take about up to 2 to 4 weeks for any kind of improvement. And before then, if somebody see the same kind of behavior, it just doesn't mean the medication is not working. It probably just because the dose is not high enough, and or it also doesn't mean that these are medication side effects, because we're still talking about the same behavior for which the medications are used to, the prescribed to treat. Um, but conversely, you do want to watch out for side effects. And side effects are from medications are a clear change from a person's baseline. So which would be sedation, falls, or confusion. Within a few days of starting the medication. So, for example, if you're trying to treat somebody with depression with an antidepressant, and within a few days they start becoming sleepy, confused, constipated, yeah, then you're probably looking at the medication side effects as opposed to medication not working. All right, okay, so that's pretty much concludes what I'm going to share with you today. And I'm going to stop sharing and have Dr. Wen take over.
Dr. Wynn, you're muted.
Okay, great. Can you guys hear me now? Yes?
Yes.
Okay, I'll get started. Okay, so yeah, so I'm a geriatrician and, see patients with dementia, and I get calls because the behaviors are just unworkable. They don't know what to do. Doctor, help me out. Give me a medication. I can't control this, right? So this is the common calls that I get. So I'm going to talk to you about some approaches that I talk to families about how do we get started? How do we wrap our care around this? Okay, so here we go. So first step is assess the situation, right? Are they a danger? Is this behavior dangerous to themselves or to others? Right? Because everybody actually has an urgent, you and I, we all want to feel safe, right? And sometimes if they have the dementia and they can't figure out what to say or how to describe their need, an agitated behavior is an attempt at self-protection, and that's why they're lashing out. And if it's dangerous, you need to remove the person or the item that they're going to wield or throw to control the danger sufficiently, and then allow time for watchful waiting or cooling off. Okay. And if the patient is in danger of seriously hurting themselves or others, it's okay to call 911. Okay. However, you should know that there are few or actually no geriatric psychiatry hospital beds available in Hawaii, and that admission to the hospital may only be for a medical workup, and that hospitalization or medications may not solve the underlying problem, right? Because after they medicate them and they a little bit more sedated or whatever, and then they go back to the environment and the situation that got them all riled up in the first place, the problem doesn't go away. So ultimately, a change of approach is still the most effective intervention. Okay, so if it's not dangerous, if you manage to take away the dangerous parts, then we do ta-da, right? And ta-da stands for tolerate, anticipate, and don't agitate. So tolerate. If it's not dangerous, allow the patient to respond to their environment, observe them, and you might get clues about what they're upset about, right? They might start muttering about this or that, or fuming, or this. They may say something that gives you an idea. What is it that's getting them so upset, right? Because they often tell you, right? And then anticipate. Behaviors are a way of communicating. And if they can't tell you, you need to think ahead and try to meet their needs and avoid the frustration or the danger. And then don't agitate. So if they can't reason or understand, don't try. Even if you're reorienting them, if you start telling them, no, today is Monday, we're not going to church today, or whatever it is, right? Go with their flow. Try distracting, try humoring them. Don't argue, don't agitate them if you know that's what's going to happen. All right. And as I said before, people need to feel safe. And so we need to give a safe approach. So this is a strategy. Actually, it's from the positive approach to care, which you'll be hearing about a little bit later. But this is about connecting in 3 ways that it's very non-threatening. So first is visual. Come in from the front so they actually see you. Stop 6 feet out, keep out of their personal space. Wave hi, and then maybe offer a handshake, maybe not, or go slowly. And then maybe get to on their side so they're not confronting them, and then get low at their eye level to connect. After you've had the visual connection, say hi. Say hi, mom. Hi, auntie, right? Or whatever their preferred name they want to be called. And then wait. They have a slow reaction time. Just wait, say hi. And they say something nice and friendly, like, oh, you have a nice blue shirt today. Introduce yourself. They may be a little disoriented, don't remember who you are, and then wait for that connection before moving towards them or moving on. And then touch is the last thing to do. And then maybe a handshake and a hand under hand. And I'm sure that Dorothy Colby will be covering that. So make sure you connect in a non-threatening way. Safe, that's the key here. What else is safe? Well, you have to be aware of your body language and speak slowly and calmly, show empathy and respect, address their feelings, and apologize. Lots of apologies. Agree with them, back off. That means try again later, right? They may be different person in 5 minutes. So, oh, I'm so sorry. I'll come right back. I'll come back later and check with you, right? Show concern. I noticed you didn't eat breakfast this morning. Can I get you anything? Can I do anything to help you be more comfortable? Listen to them. And whatever they say, do not dismiss them. Take their concerns seriously. Another tenet of a safe approach is the partnership, right? When you do something to a person, you reinforce helplessness. If you do something with someone, you promote partnership. So ask for permission and ask them to help you. Hey, I need your help. Give them limited choices and redirect. So consider their favorite food or drink or person or music or whatever it is, and then show visually and by example, and then do things together, right? And any intervention in a person-centered or a strength-based way honors the individual. So that's the thing. We really need to keep honoring the person wherever they are at. So even like saying, yes, I know you like chocolate. That's why I got you chocolate pudding for your medicine. Yes, right? And then taking care of the whole person, because there may be multiple needs. And then a very important step is to describe it, right? And you see the little doctor here on the right side of the screen. The doctor is thinking, is this depression? Is this delirium? Or is this dementia? And the way they figure it out is by what you tell them. Okay, what kind of behaviors is this? Is it the words they're saying? Are they just sounds like grunting and groaning, calling out, crying? Or is it hallucinations? Are they talking about things that they're seeing or hearing about, or things that they believe that aren't true, right? What's their behavior like? Is it aggressive? Is it non-aggressive? Is it more anxious, right? When and how often, right? Does it happen every evening? Does it fluctuate? Does it happen all day? How long has this been going on? Is this a new thing? And they're not like themselves. What is their mood like? Do they look sad? Are they looking withdrawn? Are they irritable? And how severe is this? Is this very distressing? It's impacting your caregiver quality of life. Not sure you can keep going. Or is it just a little annoying, right? So all of these things are very important for you to describe. It will help the doctor figure out the strategy of medications if needed. How are we going to treat this depending on what you're describing? And other important parts, right, of describing is doctor looking out for signs of depression. Do they have a long-standing history of depression, right? If they had depression when they were younger, it didn't go away, right? Do they have a sad mood? Looks like they have no interest in doing things they used to enjoy? Are they cranky, irritable, or resisting help, right? As Dr. Liu said, these are signs of depression among people with dementia. And then, of course, treating the depression with an antidepressant can go a long way for improving their quality of life, reducing the behaviors too. And then also thinking about looking for signs of delirium. So if it's a new behavior that just popped up in the last 2 days or so, or they have more difficulty paying attention or following directions, their sleep-wake cycles are all mixed up. They're awake at night and sleeping all day, right? Or having hallucinations or delusions. These are possible signs of delirium. And so you need to actually get medical attention right away, whether you go to urgent care, emergency room, or talk to your PCP, right? And then if these are new signs, these need to get worked out. Caregiver observations are very important. If you notice anything unusual, you need to let the doctor know as soon as possible, right? So these are some of the signs, the observations that are very easy for caregivers to do. So this is a stop and watch tool that we actually use in nursing facilities. So so things to look out for, like seems different than usual, symptoms of a new illness, or talks or communicates less, overall needs more help, or pain is new or worsening, they're participating less in activities. That's for stop. And then ate less, no bowel movement in 3 days, or diarrhea, and then drank less. Watch is weight change. This is signs for fluid retention or dehydration, looking for swollen feet, swollen legs, agitation or more nervous than usual, tired, weak, confused, or drowsy, or change in skin color, change in condition, or they suddenly need more help with doing everything that they used to do, even walking, transferring, and toileting. So stop and watch. If you see any of these things, and you know what, it happened in the last 24, 48 hours, just talk to the doctor right away. They're going to do a workup and make sure that we can treat the underlying medical problem. For example, antibiotics for infections, fluid for dehydration, right? How many times I just tell people, you know what, just push fluids, encourage fluids, and then suddenly they're doing better, right? Consider medication side effects, or breathing treatments if they have trouble breathing, or pain management. Whatever the underlying problem is, that's what needs to be treated for the delirium to clear. Depression, you need antidepressants or behavioral activation, and dementia behaviors, non-drug approaches first, and then medications as a last resort, balancing off benefits and risks. Okay, and then step 5 is use non-drug strategies. And so here you have to be a detective, right? That's what you have here. You have to have a bag of tricks, like Felix the cat, and you have to dance because the things keep changing. Not everything works for something that works for one doesn't necessarily work for the other. And then whatever worked today may not work next week. Okay, so let's talk a little bit first about being a detective. We have to find the triggers. So how do you find the triggers? What ticked this thing off, right? Look at the antecedent. What happened before they went off, right? Who was around? What were they doing? Where are they? What time of day was it? And why did this happen? What is the possible trigger? So we'll talk a little bit about that. And then, of course, being very mindful of, okay, what is the behavior, specific behavior? Is it a physical aggression kind, or is this a, verbal type of behavior? And then think about, okay, so with this behavior, what happened? Did anyone get hurt? Did they get hurt? What was the result? And what are you going to do if this happens again? Because this may very well happen again if you don't know how it got triggered. So this is the key, find the unmet need, because behavior is communication, right? And so we have to find the underlying need. This is Maslow's hierarchy of needs, right? Most important is the basic, right? Physical needs, safety needs, love and belonging, and respect, and then having a meaningful life. So everybody knows toddlers, right? They're prone to having behaviors and temper tantrums, right? And because they can't express what they need, right? So what do? You say, oh, you try, oh, let's try snack. Oh, maybe they're thirsty. Let's try some water. Maybe they're cold. Get a jacket. Oh, check their briefs. Maybe they, had an accident, right? Maybe they need a nap and rest time, right? So you need to pay attention to physical needs first, right? And I think this goes for all of us, teenagers. I have teenagers right now, right? And if they come home and they're in a funk, right? What do? You get them a snack, get them favorite food, get them something to drink, and then suddenly everything is better, right? So yeah, before doing anything, try to check out their physical needs and see if there's anything you can address in a simple way. And as Dr. Liu mentioned, constipation is very, very powerful here, right? You got to stay on top of that. Otherwise, yeah, things get kind of rough. Okay. Talking about safety needs, like I said, they have an urgent need to feel safe. And so if you can't see really clearly or hear very clearly, or you really don't know what day or time this is, life is very fuzzy here and you don't feel very secure. So maybe providing those kind of cues in the environment, or creating a calm, comfortable, and safe place for them to go to, right? Those to make the environment as safe as possible, because an overstimulated environment can just be too much, and that in and of itself can tick things off. All right. Also, we need to consider their emotional needs. Just because they having difficulty with their memory, or just because, they can't, the judgment is, they can't process complex things, doesn't mean that their emotional needs went away, right? That actually remains. And so arguing, forcing, shaming them doesn't help. All it does is rain on them. They get sad, they get heartbroken, and then they get depressed, right? So don't do things like that. But instead, right, what they always will need, what we all need, is love, feeling respected, and a sense of belonging. So whenever you do anything for the person, helping them, right, it's not about the task, right? Come on, hurry up. We got to get into the show. No, it's about being with the person, right? And focusing on the relationship. That's what's going to get you furthest, is they need to know that they matter, and they're not just a task for you. And then, of course, boredom, right? What do you think happens if you leave a toddler by themselves? Well, they will find ways to keep themselves busy, which may not be what you had in mind. So you need to take out your bag of tricks and try different things, different activities, um, sensory stimulation, meaningful activities, music therapy, those types of things to give them some joy and quality of life, and meaning in their life, at whatever level they can do it at. Okay, so after you identify the trigger, you figured out what it is, and you're able to describe the behaviors, we got to figure out what to do next. And so what's to do next here, the consequence, because we want to prevent this from happening again, we have to look at the 3 Ps, right? So we have to plan with the 3 Ps. So we have to prepare, right? So always, like, for example, have a favorite snack available for distraction if needed, right? Prevent, don't, well, if the TV gets them agitated because the news is terrible, the news cycle is very scary or terrible, don't have the TV on, right? And don't have it on at this time of the day, especially in the afternoon or the evening when they are tired and they can't handle it, right? And also always be present with them, right? If they're having a moment, right, just walk with them, acknowledge their frustration, and while you're talking to them, lead them to a quiet area with another activity that's safe. Right? So that's just being present. That's just to get them out of that. And so it's important to be proactive. Like I said, have a bag of tricks. You need to have that in advance. You have to think of the things you want to do, and then be able to do it at a moment's notice, and also for other caregivers as well. Okay, so let's talk about some of that. So sensory stimulation is actually very, very effective. People have done a number of studies and found things like namaste care or snoozelen therapy, things that are just, engages the senses, because that doesn't go away when you have dementia. In fact, these things are very pleasurable. So, having something where they have textures to touch, just maybe washing, soaking the nails, hand cleaning, right? Watching a fish tank, that's visual, tasting a lollipop or eating a snack, smelling a ginger lay, right? Or listening to bird songs. Right? These are all sensory stimulants that can, cause it improves quality of life, and it's very pleasant. So sensory stimulation is actually very powerful way of reducing agitation and also improving their cooperation with care as an activity. Music therapy is actually one of the most well-studied intervention for dementia behaviors. And it turns out it's very, very effective. And so what we mean by music therapy, it's not just you turn on the radio, right? And it's just music playing in the background. What we're talking about, it's interactive, maybe singing along, maybe playing instruments, clapping your hands, swaying back and forth, dancing or whatever, right? It's enjoying the music together with the person. That's what we mean when we say music therapy. And that's oftentimes this is, the way the studies go is it lasts, the episodes last, 30 minutes or so, and then, a few times a week. And so when you do that, their days tend to be better. And so what we do at our nursing facility is like we pretty much do music therapy for everything, right? We engage in music therapy for morning exercise. We use music therapy for just music in and of itself. We do it for other, uh, you know, practicing, strengthening your voice and stuff like that within song, right? And playing instruments. So all kinds of things. If you have other, holidays to go for, then you start singing those holiday songs, right? All kinds of things. So if you can incorporate music therapy in everything. The other thing is you can actually create these playlists, right? And now it's easy, right? When you have like Spotify or Apple music or something like that, right? Then you can create these, you can go ask the families and put together playlists that they're very meaningful, that they're favorite, they love this type of music when they were younger. And then create the playlist or have headphones or have them, them do the headphones, well, then speakers, right? And have those as part of your routine each day, or maybe target it like, oh, just before we do showers, right? We always do music, right? And get them in a really good mood, and then we go shower or whatever it is. It's so targeted that there's many ways to use music therapy. And then meaningful activities, right? So meaningful activities, I think I see it right here, right? Include all different categories, like could be self-care. Self-care is taking care of yourself, maybe doing some stretches, some exercises, going to the hairdresser, getting your nails done, right? That's self-care. Work activities, being productive, maybe planting, watering, uh, things like that. Relaxing activities such as petting a dog, looking at the fish tank, uh, things like that. And then, of course, make sure you celebrate special occasions whenever you can. And most importantly, of course, it has to be person-centered. Something they care about will be meaningful to them, something that they've cared about all their lives. So really needing to do that. Now, what I would suggest really is to act, because it's hard to come up with it all of a sudden, and things work better when you have a plan, right? And so it's good to have a plan, make a calendar, right? Make a daily plan with pleasant activities involved. So behavior activation is a type of therapy used in depression for people who are not necessarily have dementia, but this actually works in somebody with dementia as well. for somebody who's kind of irritable and not cooperative, and maybe some aspects of depression, is actually you do a pleasant activity, something that they enjoy, and then as they do it, their mood follows, right? And so for example, me, every day let's get some music to start the morning, for example, or you might do that in the afternoon, right? And then get the nails done, or on Monday, and then you do the exercise every afternoon, right? And then whatever comes up in the evening. Tuesday, you got a movie plan. Maybe the movie is a dog movie because they love dogs, right? Wednesday, maybe, we'll read some letters from family. Could be letters you've read before, or look at the old photos that you've looked at before. That's okay, right? Thursday, for I sit in the garden and listen to the sounds. Oh, do you hear the bird calling over there? Yeah, yeah. What do you hear else? I hear the leaves rustling. What's going on? Oh, there's some construction going on down there, right? Down the block or whatever, right? And so make a plan and fill it with pleasant activities. And of course, this looks hard if you're the only one doing it, right? So you need to enlist a team. You need to enlist others, and it takes a team. So make sure that you're not the only caregiver around. It's more successful if you have people who can, jump in here and there for you. And of course, one size does not fit all, right? If you've met one person with dementia, you've met one person with dementia, right? As I said before. And then of course they go change on you too, right? Because in 2 weeks they like something else. So that's why we must learn to dance. We call it the dementia dance, right? You just kind of have to keep going with the flow, agree with them, whatever, no matter what, and then figure out another strategy and get another tool from the toolbox. And so with that, I am ending my slide and handing this over to Dorothy Colby. Thank you, Dorothy.
Okay, I will get my slides up here. Here we go. Let me go to full screen. How's that? That looks good? Okay. Okay, great. Thank you so much. I just wanted to together to build on what Dr. Liu and Dr. Wen shared, and kind of at this point in this our time together to to become more concrete about what we're looking for. And Dr. Wen mentioned being a good detective. I actually happen to have a detective hat right here. Doesn't really fit over my headphones, but it's a literal little detective. So if you remember those old Dragnet shows where the detective comes up with their book, like just the facts, ma'am, have something concrete. Think about for yourself for the moment. What are you going to start writing down? Where are you going to be writing it? And what are we going to be looking for? We're going to look at what makes these challenging situations happening. And I want to purposely shift a little to the term situations, although we've been talking about challenging behaviors, because when we're talking about these challenges, the person with the behavior that we're describing is not alone. We're in this situation together. We're going to be looking at the unmet needs, and we're going to be looking concretely about brain change and what our role is. And so we are the most critical part of their daily lives, and it's our relationship that's key to make life worth living, and to really hold in your hearts and minds that people who are living with dementia, even in all these extremely challenging situations, are really doing the best they can at all times with the brain change that they are living with. And we are the ones, and everybody can like tap your heads now, who have the healthy, typical aging brains that are here to support the person. So we are the ones who must be willing to change. So in the course of our little short time together, I'm going to ask you to actually use your hands from time to time to do these things with me. And this is to activate your brain. And if anybody around you asks you, what are you doing, waving your hands around and tapping your head, you can tell them, I'm activating my cerebellum to cement some new information. So we're going to look at because it's all about brain change. These things that we're seeing, hearing, feeling, tearing our hair out about, getting exasperated and sad about when we were trying to support the person that we love so dearly. There's a reason behind what's happening. So there's two parts of the brain we're going to look at. So if you could touch the front of your head, we're going to be looking at the frontal lobe. And we're also, if you could reach deep inside your head with these fingers, we're going to be looking at the amygdala. Those are the two parts we're going to look closely at, and for you to be able to use your detective skills. Yeah, I am also all for dancing. We have to learn to dance with the partner, because we're going to either be doing this. You can do this with me. Yeah, coming like this, or take your two hands like this. Are we going to be able to come together so that we can move forward together to a new and better place and time and space, as opposed to trying to drag someone to that place, coming together. So for that, we definitely learn to dance, learn to recognize when to stop and back off. You can make a little timeout symbol or press the pause button. Take a deep breath. That pause is for you, because you're in this too. It's as equal a challenge for you. And this sounds like a simple one, but it's not. Being right doesn't necessarily translate to a good outcome. You know you're right. Oh my God, you know you're right. It's not Sunday. We don't go to church on Sunday. It's Monday. But you're right. Your correctness doesn't necessarily translate to a good outcome if you try to convince me otherwise. So I'm going to do, this is for where we're going to cement this in our cerebellum. These clues that we're going to be looking for. So if I have my detective hat on here, um, uh, doctors Lou and Wen went through some of the physical things that can be leading to challenging situations, behaviors. But let's do them with our hands. So put your thumb up here, and you think the old school, suck them up like this. Intake. We have to get these things in order to have good function, and that includes good brain function, hydration, nourishment, meds. And did I not take my meds? Did I double take my meds? Things are happening with the intake. Your second finger, energy up. I have a ton of energy. Unfortunately, it's in the middle of the night because I slept all day. Or maybe I have no energy. I'm completely exhausted. Maybe it's because I was up all night. But that energy flow. Number 3, output. We have these things we need to get out of our body. Urine, feces, sweat, saliva, tears, those things have to come out. If there's any obstruction with that or any malfunction in that processing, that is going to affect our overall systemic health and our brain health, and how we're able to function. So if you think about the times that you have been constipated, and if someone asks you to stay seated in a chair for a long period of time, for example, a wheelchair, with that feeling, what would your reaction be? A lot of squirming, probably, maybe a lot of efforts to get up. And someone keeps telling you, sit down, you're going to fall. Whew, that's not a pleasant feeling. And it's when we feel something uncomfortable, we do something. All human beings living with dementia are not. Number 4, discomfort. It's kind of hard to put this finger down, isn't it? So things that make me uncomfortable. Is this place friendly, familiar, functional, and forgiving? If I don't feel those things about a space, I'm going to leave, or I'm going to want to leave, for example. And then the 4 S's: space, sensation, surfaces, and social experiences. And kind of back to the chair example, if you're asked to sit in a chair that's too hard for too long, that discomfort's going to make you want to move. The pinky, small but extremely mighty, pain, physical, emotional, spiritual pain. And as the doctors noted, I might not be able to articulate that pain to you anymore, but I'm showing it to you, perhaps in some things you might consider very unpleasant, being extremely grumpy, more than irritable, lashing out. But underneath is a pain that is being undiagnosed. Now, take that hand that you did those 5 physical unmet needs, give it a close, and take your other hand, put it over it. These are the 5 expressions of emotional distress. Sometimes these can be masking these underlying physical needs. So I am angry. You get up out of my room, and I might be feeling some of these, but that extreme constipation, for example, is that, or some other kind of pain, but I'm lashing out with anger. So what's underneath that anger? That anger, that first one, the thumb, can cover up the next four. Sadness, number two. Loneliness, your third finger. I feel at the extreme end, abandoned, trapped. Number four, scared. I'm on the high end, terrified. And then the last one, another small but mighty one, bored. I'm not just disengaged. There's no point. I feel useless. So these are, when you're seeing changes in emotional distress, or looking at the physical needs, these are what you're going to be looking for, and taking notes and keeping a log for sharing with the physician. Because one of the things of the purpose behind being such a good detective is to help gather data, help support, and figure out really what's going on underneath. Is it solely related to dementia? Nothing's ever solely. We're complicated beings. Uh, but we're to be able to work with the physician and your whole care team to move forward. So I want to take a quick look at a couple of brains. The brain on the left, the larger one, is an individual who passed away from a car accident, but without any neurodegenerative disease, no Alzheimer's disease in this case. And the one on the right, someone who passed away from Alzheimer's disease. So when we say they're the same age, they're the same gender, and they have the same head circumference, so the skulls were the same size. So when we say it's all about brain change, we're really talking about physical brain change. And so if you look at it, some things that might pop out to you, the color, the shrinkage, there's this physical change. And we're going to look closely at what this physical change means for the person who's living with those changes and you. What are the behavior changes you're going to see? What situations might you find yourself in? So here's where we're going to be using our hands. I'm going to have you take one hand, put it on your forehead here. This is your frontal lobe. And as if you could like just take this little front up part off and look at it. This is the person in the second brain who passed away after 10 years diagnosed with Alzheimer's disease. And then this is the person who passed away in a car accident. So the functions of the frontal lobe, where you're going to see some clues for your detective agency. Number one, I'm going to have you put your hands out and like imagine you're riding a horse and the horse is a runaway horse. You go, whoa, like this, whoa. Impulse control. I can pull the reins back. Ooh, I already had 2 donuts. I shouldn't have a third. Oh, I have maybe an unkind thought. We all have them sometimes, but I can zip it. I have impulse control. I can think something and not say it. So someone who is living with brain change, the frontal lobe is often affected earlier and more severely, and in certain dementias, quite severely early. You start to see clues about impulse control, changes impulse control. To be logical, to take in data, everybody do this, ting, ching, to take in data and come to a reasonable, rational, logical conclusion, right? I can't find my purse, and instead I jump to immediately someone stole it. The neighbors are coming in the house and stealing it. That is not a reasonable, rational, logical conclusion. And it's a clue that there's changes in my frontal lobe. Making choices, this or this, making good choices. That is also affected. The next one, you put your hand out like this. This is a task. Starting a task, so able to get started, sequencing through all the steps, finishing it, and moving on. Any break in this is a clue. I can't get started. You put the food down in front of me and I just can't start. You get me started with the spoon. I'm eating. There's no more food. I'm still scraping the bowl. I can't complete and I can't move on. Those are clues. Self-awareness. Everybody pick your hand out, and this is the mirror you're looking in, and you're doing a self-assessment. Look pretty great today. Awesome. But also you can assess what you're good at and what you're not good at. So you know, use that hand, when to ask for help. And the important part about this is accurate self-assessment, accurate self-awareness. So as we start to have changes in the frontal lobe, my assessments might not be so accurate. So with my grandmother, for example, multiple times sideswiping the garbage truck, the garbage man's had to leap off to save her life. She had no self-awareness about her driving skills. Everything seemed fine to her. It was obvious to everybody else it was not fine, but in her mirror, she was not getting an accurate reflection. And then the other one, take your other hand, so you have your point of view, and then you recognize that other people have their point of view. And we can come together to come to a common understanding, even if we don't agree. But if someone cannot see the other person's point of view, it can lead to a lot of conflict. So we are the ones who might be able to come around, Dr. Wynn said, to join them where they are. So then we can move forward without the arguing and butting heads. So I would say the main thing to remember, and being a detective on this one, is with these frontal lobe changes, they think it, someone thinks it, they're going to say it. If they want it, they're going to do it. And if they see it, they're going to use it. So if I see other people's food or sweater and I'm hungry, I'm just going to take it because I'm meeting a need for myself. The second part of the brain we're going to look at is the deep primitive brain. So if you're this brain here and the PET scan on the left, the red is high burning, glucose burning, this little part right in here. And then this is someone with early Alzheimer's, and there's those primitive brain centers. And then this is late, before the end of life, pretty much. And this is an 18-month-old child. So if you look at the primitive brain changes in the course of the disease, one interesting thing you might note is in all the other areas, this is the frontal lobe that we were looking at, a lot less red, a lot less activity, but in the primitive brain more. Why might that be? When we think about what Dr. Wen said about when things are fuzzy, when this is not making sense, we don't feel safe. And our primitive brain is what keeps us alive. It's our survival center. So when I am starting to have challenges with all parts of my brain, I'm more on the alert. Our brain is trying the best it can, living with brain change, to stay safe and also meet our needs, meet those unmet needs, and to seek pleasure. So it's all about the amygdala. So when other parts are failing, the amygdala is the one that can be really driving the bus in a sense. So it's going to be in charge. So I'm going to have you, whoops, let me go back a little bit. Take your hands out here, and we're going to, here we go. Your left amygdala, go like this. You're going to be scanning for danger, scanning for danger. Everything looks okay. Maybe something's a little worrying. It might come up here. And then at the very top, danger, danger, danger. Fight, fight, flight comes on. When that comes on, that is completely in charge for us or someone living with dementia. So go everybody take your hand like this and go fright, like flight, you're gonna run away, fight, punch. There's also hide and seek. Help me, help me. I don't feel safe. These things that I'm doing are to try and keep myself alive. They are labeled as aggression, combativeness, all those things. And indeed, those words do describe some of the things we're seeing, but as a detective, what's underneath it? Why am I so fearful? And on the right side, we need pleasure. We need things that bring us joy, and we need to be free of pain. And when that one is brought, I want some chocolate. I would like some chocolate. I need some chocolate. I have to have some chocolate. That's an extreme example, but I will do anything anybody been hangry, for example? I need it now. I need the pleasure now. That also can be a really challenge. So what we want to try and do is in our detective work, be aware of what's happening on the lower levels of these arrows before it gets to the top. And by taking those notes, by being in active communication with your geriatrician, with the geri psych, other family members too, so everybody knows what's happening, to see what those triggers are, how can we, when we see things starting to, someone getting overstimulated at the same time of day, every day, if it's every day off the charts, what can we tweak? What can we change? Just bring it down a little. We're not talking about a magic wand that's going to make everything okay all the time, but how can we be supportive in a proactive way? One of the, Dr. Wen mentioned it, one of the very common, very easy ways that we don't realize that we're triggering that fight, fight, flight response in someone is just by where we physically are. A person's peripheral awareness is changing as dementia progresses, so they really start to pay the most attention to what's right in front of them and aren't aware so much on the side. So when we're right in the front, leaning in the wheelchair, hi, you ready for your meds? I'm blocking everything out. It can feel quite threatening. And we don't realize that we're not trying to be threatening, but just being on the side, whether it's standing a little to the side, sitting to the side, can make a huge difference in how the person you're trying to support perceives you. Dr. Wynn already touched on these, making real use of visual cues with everything we're saying. Stand up, let's go. Are you thirsty? Keeping it simple, keeping it visual as well as verbal, and getting connected visually, verbally, before the touch comes. So, what should we do? Well, one is what you're doing today, build and use skills. You're here, you're learning about brain function, you're learning about how to have a constructive relationship with the person you're supporting, but also with the whole care team you're building, your physicians and everyone around. And keep in mind who has the healthy brain, and also that people living with dementia are really doing the best they can. I can't stress that enough. And to also recognize yourself in this journey, and that we are all, as Dr. Wen said, if you met one person with dementia, you met one person with dementia. The same goes for care partners. We're all individual. Whew, and as the day we change also as we get older and as we learn things too, we gain some wisdom, and we're also not the same all day. I'm much sharper in the morning and less sharp by the time 9 o'clock rolls around. So recognizing your limits, your self-assessment, and give yourself the same grace that you strive to give to the person you're supporting. Recognize you will make mistakes, and that's how we learn. Take those uh-ohs and then turn them into those ahas that, oh, that didn't go how I wanted it. But don't beat yourself up about it. Let's rethink this. Maybe get someone else in, because when you're too close, it's hard to see because you're really in the thick of it. Sometimes in the weeds, as they say in the restaurant industry. Give yourself a chance to try something and get support. It's planning ahead, not if, when, and watching yourself for signs of burnout. And sharing with the physician, not just what you're observing in your journal about the person you're supporting, but about yourself. Make note for yourself too, because you and the person you're supporting are a team. One can't do without the other. So keep those in your notes too, and set limits for yourself. Build a care team to support you and the person who's living with dementia for the long journey. Okay, so I'm going to pause here. Just you'll have these in your slides. There's a lot more information about the positive approach to care. Alzheimer's Association has some great support groups, both in person and online, and they have a 24-hour helpline for caregivers that is answered locally during regular business hours here, but it's 24 hours. And Catholic Charities has an incredible library of dementia-related webinars and videos. So I'm going to stop here, and let me stop sharing here, and Jody will come back on for the panel Q&A.
Hello. Hello, everyone. Thank you so much for being here today. This was our first attempt at an expert panel, which is going to be a series focusing on dementia behaviors. These three are the dream team for giving different perspectives of challenging behaviors. And we ran late because of their incredible information, but I think Dr. Liu can stay a bit late. Dr. Wen, can you stay a bit late? And Dorothy, how are your schedules? Thank you so much. We have 13 questions that we will rush through right now. Okay, I'll start at the beginning. This is for Dr. Liu. Hello, your thoughts on RX mirtazapine 30 milligrams for depression with dementia and some irritability, 86-year-old male. I don't know what the question is, just your thoughts on that medication, Dr. Liu. I think you're muted. There we go.
So among all the antidepressants, mirtazapine is considered a stronger antidepressant. So it can be very effective if a person has dementia, helps with if the person has depression. It can also help with the sleep, help with the appetite. But sometimes, I see mirtazapine used for people with dementia without depression. And the fact that mirtazapine is such a strong antidepressant, it can kind of like rev a person up, makes them more agitated, more confused, more aggressive. So it's, again, going back to the double-edged sword. It's a very powerful antidepressant as long as there's underlying depression. But if you just using mirtazapine for dementia-related poor sleep or appetite, yeah, just have to be careful with the agitation and the risk of confusion and constipation too. So it just depends on what the focus of the treatment is.
Thank you. Resident requires assistance with every transfer, toilet, bed, bathroom. Initially, resident would cooperate, but then in the process of transferring, resident would suddenly become agitated, scratch, hit, and or spit at caregiver. I'm not sure what this question is. This is something perhaps because it's a resident that Dr. Wen or Dorothy can address.
Sure. I guess, it depends on which exactly you're targeting here. I've had patients who spit everywhere. And, maybe the first thing I think about, well, if they're spitting, if I can't make them stop spitting, so maybe I have to give them a tissue to spit into, or I think about, are there medications they're on that's causing them to increase their saliva? Maybe we need to change that medicine. Or things like that. But if they are initially cooperative and then they suddenly change, then you got to think, well, how's the approach? And it may be something like talking them through the entire time, talking story as they're going along and telling them what's next, what's next, what's next. It may help with that. I don't know, your perspective, Dorothy?
Yeah, it's the type of spitting makes a difference. I've certainly known people living with dementia that like spit everything out on the floor, and that's different than spitting at someone. Spitting at someone is a self-defense behavior. So you want to scratching, hitting, biting, spitting is what we do when we are extremely threatened. So my first thought on it is if someone is described as cooperative in the beginning, and then when the actual act of bathing starts, perhaps they didn't understand what you had said in the beginning, and you oppose no threat. Like, are you ready to, you say, are you ready to take a shower now? But they hear, you ready, Tanya? Yeah, you're a smiley lady. Yeah, okay. And then you wheel them in. Okay, yeah, okay, ready? You're taking my clothes off. What the? So there's a disconnect between I think you understood, but really I didn't. And so I would say going down to start with bathing. My small soapbox, very small soapbox about bathing is to think of bathing not as showering, not as hosing someone down from top to bottom, but as hygiene. So sometimes that might mean if someone is so agitated and terrified by showers, it's all about hygiene. The spots, under women under the breasts, armpits, hairy areas and things, you can spot clean that. And also the head is the most sensitive, and they become hypersensitive. And so maybe starting lower with the feet first, less threatening, having drapes and things, but taking it slow, very slow, one thing at a time. And is there anything they can be involved with, like maybe they washcloth, they're only going to rub the same spot over and over again, but that's something they could be involved with. But that behavior that's described sounds like active fight amygdala response.
Thank you. I think that person that asked the question, if you look at our recordings in our archive that you got on the slide, the link, you'll see some of Dorothy's trainings from COVID time. Around summer or fall, we did a recording of 6 of Dorothy's sessions. And I think maybe you can get insight from watching those, or we can keep in touch with you about attending more of Dorothy's trainings, live or online. Okay, next question. I'll be escorting my aunt who has vascular dementia on a long flight, 16 hours. Uh-oh. So that she can relocate to the country she was born in. She also has mobility issues and uses a wheelchair. What strategies, medications can you recommend to me to make her more comfortable on this journey at the airport and on the airplane? She currently lives in a memory care home in another state. Dr. Liu?
Yeah, sure. A couple of things. Yeah, it's a pretty long flight. So it probably would be, think about non-foreign interventions. So this is where if a person has like a familiar object, kind of like a analogous to a safety blanket, something that's, like something she likes, he or she likes to hold, or there's a family member that can escort the patient, just, that brings, bring that sense of familiarity during the whole trip, it can go a long way. Otherwise, if you're concerned about agitation, this is where you'd be good to do your due diligence prior to the trip to try, different types of as needed medication at low doses to see exactly what low dose as needed medication can be helpful. Just to lessen that restlessness, lessen agitation. It could be something as, simple as, low dose trazodone. Somebody who is very, can get very aggressive, maybe low dose risperidone. Sometimes, we try to avoid benzodiazepines like lorazepam, but sometimes it does work for people and who would not respond to trazodone or antipsychotics. So this is where, again, before such a long journey, it's very reasonable to try different types of as needed medications to see which one is effective. In addition to provide some sort of familiar connection, either via objects or a person escorting the patient.
Dr. Wen and Dorothy, just really quick, I know that we're running late and we shouldn't get any more questions, everybody out there. We should just address the ones that we have. Anything come to mind? Any quick tips for a long flight?
I'd bring a headphone with music that they really, really enjoy and maybe kind of interact with them. And then also maybe some sensory things and things to look at, like activities for, keep them occupied and distracted. Good snacks that they like.
Keep the airline informed, arrange for early boarding. If it's possible to go first class for space and just less stimulation, it might be worth it. Yeah, another tip is to wear, if the person is agile, wear the same color, like weird color sweater or something, so you can find each other really easily, and take a picture. So if someone wanders off, you'll be like, here, we're both wearing this same, same reindeer sweater or something like that. And it's also be something to connect you and laugh about too. But yeah.
I would say bathroom assist is important, and first class, if you can tell the airline ahead of time, like Dorothy said, that you have a loved one with dementia. I did this with my father on a long flight from Florida, and they sat me up front right by the bathroom, and all of the flight assistants would walk he and I to the bathroom, and I would assist him, and they covered it with a curtain for privacy. This was a godsend for me. So I would say, yes, sit near the bathroom. And anyway, that's it.
Okay.
So we'll move on. Reapproaches may help at times. This was advice for the person in the facility about the spitting behavior. As soon as a resident spits, caregivers would try to dodge, which puts the resident at risk of falling while in the process of being transferred. Yeah, we already talked about this. You could look at some past recordings that we have. Moving on, resident requires assistance with every transfer. initially, oh, this is the same, the
Mm-hmm.
scratch hit part,
Mhm. Yeah.
and how the caregivers try to dodge, you know,
Mhm.
which puts the resident at risk of falling. So this is an issue. That person is anonymous. Could you email me, the person that wrote that, so I know who you are, so I can send you some resources about this, perhaps? That would be great. What can caregivers do if they refuse to take meds? What's the safe way to help loved ones with dementia to ingest meds? We'll start with Dr. Liu.
Sure. Yeah. So first of all, we want to make sure that it's ethical. So if we're looking at, mixing medications in their food or drink, make sure that the children or the surrogate is agreeable, with the decision. And I will usually ask them, once it, comes to time to mix, is there like a favorite food or favorite drink? This person would always drink or eat, and that's where you want to start, by mixing the medication in them. Some of the medications come in a liquid form, some of them can be crushed. So I will usually ask a caregiver, whatever is easier for you. Is it easier for you to mix the medicines as a liquid or crush as a medication?
Additionally, I would also rethink the medication, all of the medications in general, and say, well, do they need that many medications? And can we simplify anything? So if they have to take 15 meds and this is another med, one more med, no, right? But if we can, like hey, we took away 5 or 6 different meds and now we have this one to replace them all and it'll help you feel better, sometimes that goes a long way too. So you really have to also rethink your medications, the number of medications and the timing of the medications. Dinner time might be easier or breakfast time might be easier. So, and sometimes, any time is fine. I've had patients like they refuse all day long. And so even though the prescription says to take at night or take in the morning, you know what? If they'll take it anytime during the day, that's just keep offering it different times a day. And if suddenly at 2 o'clock they take it, yes, go for it.
Okay, moving on. Is donazepam prescribed to help with apathy? My mom's neurologist is prescribed to quote unquote help slow the brain decline due to Alzheimer's. Should I talk about stopping that RX? Mom is still very physically active. She does suffer from depression since my dad's passing 2 years ago. Dr. Liu?
Yeah, sure. So dementia medications like Aricept or donepezil, it can be prescribed to slow down the memory decline. But again, it's not a cure. It usually can slow the memory decline by, average of 6 months to a year. But the other reason for prescribing a donepezil is, what I talked about earlier, is for apathy. Other, stimulants being a different option. So it just depends on what what the Aricept is, prescribed for. And then one thing you want to be careful is, medications do have side effects, and medications like Aricept is known to cause a lot of loss of appetite, weight loss, and stomach upset. So if you see any of that, you may want to consider lower dose, or just let the doctor know this is not the right medication for the, for the patient.
Okay. Does sleep apnea contribute to dementia?
Yes, that's the short answer. But I think there's a lot of other things to consider as well. There's a lot of, I guess, brain health, thinking about, the smoking, the diabetes, the hypertension, good diet, all that sort of stuff, and good sleep and and addressing sleep apnea also slows decline.
Next question, what is multiple systems atrophy? My dad was diagnosed with this. Anyone?
Yeah, okay. Yeah, so multi-system atrophy it's one of those it's a neurodegenerative condition that seems to affect the speed of speech and the speech of your motor movement. And it also can be associated with dementia. It is one of the lesser common type of dementia forms that I talked about. Um, Kind of like a Parkinson's like progression, by with some subtle differences, like but so that's kind of what it is. There's not a specific treatment or cure for MSA. But then we do try to lessen the behavioral symptoms, very similarly to how we would try to lessen the behavioral symptoms, with medications or non-medication approaches.
Thank you. What would the disease affect them to know they are hungry or not? My husband puts on a lot of weight. I wondered if he knows he's full. I saw a change of taste buds. He loves sweets now. Everything is too salty for him. I'll let Dorothy, the chef, the professional chef, answer this.
Yeah, yeah. And you see me smiling and nodding. Yes, yes. So there is a change in taste processing. So sometimes I've heard it called becoming like a super sweeter. So maybe I liked like 1 or 2 sugars in my coffee originally, and now you're seeing me put like 6, and you're like, oh my. And yeah, I need more to have my brain pick it up. So you do start to see them enjoying or craving more and more sweeter things. And back to the medication question, that is often something that if you had to do a crushed or something medication, sometimes in something that's very, very sweet, if they are experiencing that type of change. And yes, the ability both to detect a process if you're full or if you're hungry. There's the opposite one, they're not eating. They shouldn't they be hungry, but they're not picking it up. So the signaling system is just not functioning properly. And then the impulse control changes about the frontal lobe. So what I see and I'm eating, if there's lots of snacks around, I'm just going to keep eating them because I don't know. I'm all about the now. If I see it, I'll eat it. Any other additions to that?
I was going to say same thing. They're stimulus bound. Whatever's in front of them is what they see. And if you don't want them to see it, you take it out of sight, out of mind.
Thank you. My 86-year-old father is doing well on mirtazapine for about 1.5 years now. Started at 7.5 and then 15 and now staying at 30. I don't know whether this is a question or just following up with that mirtazapine question. Does this look okay to you, Dr. Liu?
Yeah, that's fine. I mean, 30 milligrams is still not a very, very high dose. 30 is probably what I consider upper normal range for mirtazapine. If he's doing really well on that, not having any side effects, not agitated, not confused, not constipated, that's fine. It's a very appropriate to continue that, especially the father has recurrent depression, which is a chronic condition that would require long-term treatment with antidepressant.
What do you think is a good antidepressant to start with? Zoloft?
Yeah, so if again, if we referring to mirtazapine as something that's a little bit stronger among antidepressants, I usually would start with maybe something not as strong. Again, this is going back to the selective serotonin reuptake inhibitors, sertraline being one of them. The other two that I like to use would be citalopram and escitalopram, or Celexa or Lexapro. That's sort of the commercial names. I may have a preference for citalopram or escitalopram because the studies do have more support for the effectiveness and tolerability for dementia-related sort of agitation, disinhibition for citalopram and escitalopram, more so than sertraline or Zoloft. So sometimes if they're not doing too well, they're still irritable, easily agitated on sertraline, I would switch them to a citalopram, and usually I would get better results.
Wow, thank you so much. Dr. Liu, did you mention that antidepressants shouldn't be used for someone who needs antipsychotics? My brother has schizophrenia and he is on mirtazapine for his depression. Could you comment on that? Thank you.
Okay, I think what I say was, antidepressants can be as effective as antipsychotics for psychosis in dementia. But conversely, if a person has a primary psychiatric illness like schizophrenia, that person usually would need antipsychotics to decrease the degree of hallucinations and paranoia. But often, sometimes I see patients, that get older, the degree of their psychotic manifestation from schizophrenia is not as acute. And sometimes they can get by without medication. So it all just depends on, whether, how much residual psychotic symptoms there are from schizophrenia, and whether that leads to distress or dangerous behavior to warrant a treatment. And if the treatment is warranted with medications, yeah, it probably would have to be an antipsychotic.
Okay, just two more questions. Seroquel was prescribed for my husband's agitation or behavioral issues, first instance. But after looking at the side effects and contraindications, family revoked authorization. We are concerned about the rush to pretty serious drugs, not advised for older dementia, diabetics, death, question mark.
Yeah, so I get, okay, I can answer that. So, not, there's no medication that has no side effects. And going back to what we talked about, what Dr. Wayne talked about too, it all depends on benefit versus risk ratio. If a person is just agitated, is easy to redirectable, responding to approaches that Dorothy and Dr. Wayne had talked about, there's no need for medications at all. But then if a person has a lot of physical aggression to a point that, you're looking at emergency room visits, cannot stay with a caregiver safely, then that benefit from antipsychotics, for example, would outweigh the gain. And just because somebody is on antipsychotic doesn't mean that person will get side effects for sure, the long list of side effects you read about. So what we usually do is we start with a low dose, and then just watch for side effects. And usually if they're doing well at low doses for the first couple of weeks and tolerating that, then you can probably increase the dose safely. So it just all goes back to weighing the benefit versus the risks.
Thank you. There is one moment.
I would also throw in the converse, right? Where if they're on it and it's kind of, and the situation changes, or if they're on it a while, you can consider dose reduction and then reduce it slowly, gradually, and watch and see if you can manage the behaviors better one by one, and then taper.
There's just a few suggestions now that we're done with Q&A. A suggestion about TSA has a program to support going through security, check airport, use wheelchair assist. Yes, yes, and yes for that. And someone recommended one of those blankets for the plane where they have pockets and things, zippers and stuff to play with for a person with dementia. Do you each want to make a closing statement about this issue today? Any overall thoughts? Could you start, Dr. Liu?
Over thoughts about what we talked about today?
I guess the importance of diagnosis comes to mind, that none of this, you have to have an accurate
I
assessment,
see. Yeah.
perhaps.
So I would say, going back to diagnosis, yeah, some of the telltale signs of dementia progressing or starting is short-term memory. So if a person start having trouble remembering what had just happened, or what they ate for breakfast, or what they did earlier in the day, sort of a short-term memory deficit, that's usually one of the first signs of, we're looking at some sort of a beginning of a memory decline. Sometimes I get family members telling me that, well, they could remember, exactly whom they went to high school with, everyone's birthdays. Those are remote memory. And in memory decline, in dementia, remote memories are last sort of fastest of memory to go. It is the memories that is the first type of memory to start to deteriorate. So just kind of look for those.
Thank you. Dr. Wen?
Yeah, I would also just highlight the importance of just recognizing when things are changing, because depression and apathy and dementia often they have look the same, and so it's really important to distinguish those things, because then if you don't address that, they will just wind up having more self-care neglect and weight loss and a lot of decline functionally as well. So yeah, if you're noticing any changes, you have to be on top of things and watch. Maybe I would say watch what they're eating, weight loss. kind of things, how they're spending their day, and then you may start to see some changes that point to that, and then of course get an evaluation so we know, so we can prevent any further unintentional decline.
Dorothy?
I would just say, it, don't do this alone. Build support for yourself, um, and build a wide care team. Includes people like our esteemed doctors here, but also personal circle. Build a supportive care team and build it early. And it might be some family members, it might not. You might need to reach out beyond that. So it's never too early to ask for help, and especially help for yourself.
Well, it's time to thank you guys. You are a treasure in this community, each one of you. We're very lucky to have you here and to be so generous with your advice and expertise and compassion. All three of you have those. So really appreciate it. Everyone, there is an evaluation survey, a very short one, we promise, that'll pop up after we're done today. And just thank you all for being here. And we're sorry about all those questions that you had to answer when you registered. But okay, we do record this. I'm gonna send everybody a link to the recording and the slides later. Thank you all for being here. Have a wonderful rest of the week.
Thank you.
Bye-bye.
Bye
Bye-bye.
bye.